I'm privileged this afternoon to interview Dr. W. Eugene Stern. Dr. Stern is one of the leaders of American neurosurgery. He was the founding chief of the Division of Neurosurgery at UCLA School of Medicine and is now an emeritus professor of neurosurgery at UCLA. I've known Dr. Stern for many years, in fact, trained under him and then later joined the faculty of the Division of Neurosurgery at UCLA. And this will give us a good opportunity to meet Dr. Stern this afternoon and find out a little bit about what made him become a neurosurgeon in the first place and how things went from there on. Gene?
Thank you, Rick, very much. You're very, very good to do this, and I appreciate it very much. And Rick Batzdorf is also a nationally recognized and respected neurosurgeon, one of our finest products. My career in neurosurgery began in the University of California, and I did my straight surgical internship in that institution when the university had just one medical school. And my first rotation was in that straight surgical internship during the war years was on neurosurgery, a very busy, exhausting, undermanned service. And apparently I did all right because farther along in the course of my basic surgical training, the professor said, I want you to come on to neurosurgery. And after giving that some thought, over which I had, I guess, relatively little control, the choice was made. That was in the time when the military permitted 3 rotations of 9 months each, a total of 27 months basic surgical training, at the end of which one was given a military specialty number. And then the training was completed after my military service.
Gene, tell us, the professor who asked you to take on neurosurgery was who?
The professor was Howard Naffziger. He became my father-in-law in the latter part of my years of training. And I married his youngest daughter. And wonderful, wonderful woman. We were married for 43 years before her death. And she deserves as much credit for anything that I've accomplished as anybody else.
Well, she certainly was highly esteemed and loved by all the residents through all the years that we were together.
Wonderful gal.
Tell us, and Dr. Naffziger ran what they call a pretty tight ship in those days?
Indeed he did. Tough disciplinarian, excellent teacher, a good surgeon. He had founded the first basic surgical educational program, graduate medical educational residency training program in surgery, I think west of the Mississippi at the University of California. And he imported Glenn Bell from University of Cincinnati. He went on and held high office in a variety of organizations, was president of the American College of Surgeons, and highly respected, man with a wonderful sense of humor, splendid father to his family, and a great chief to work under. Great, but you didn't slough off in any way when you were on Howard Naffziger service.
So you then spent some time in the military before you finished your neurosurgical training?
It took 2 years in the center of the training, and then I spent, at the end of the military training, a short time back at the University Hospital, and then a year in Great Britain at the National Institute, at the National Hospital at Queen's Square in organic neurology, where I came under the influence of Sir Charles Symons, and another one of my heroes, and then returned for a year of laboratory work at Johns Hopkins under A. Earl Walker, and finished the actual surgical training in the residency at University of California, December of 1951.
And where, by the way, were you in the military?
all on the state side. The first place was Daytona Beach, Florida, where I was assigned to a convalescent hospital filled with peripheral nerve injuries, where I learned my peripheral nerve anatomy and physiology and saw the pathology of peripheral nerve injuries in depth. And then at Letterman General Hospital at Fort Lawton in Seattle, and back to Letterman, where I finished on the neurosurgical service in San Francisco.
So that dovetailed nicely with your surgical training in San Francisco.
Right, it was. Excellent.
And then you were being recruited for a job in academic neurosurgery. Is that
well? I like to think, yes, I like to hear it put that way. I had two job offers. One was to stay in San Francisco, and the other was to join the new medical school here in Los Angeles at the University of California, Los Angeles, where the second medical school of the University of California system was being, or was in fact established. And William P. Longmire Jr. was the founding professor and chairman of the new Department of Surgery. And he invited me to come down and look at the situation.
Tell us what you saw.
Yes. What I found in the fall of 1951 when I came down was, number one, unusual. It was raining very hard down here in Los Angeles. Number two, there was a great excavation at the site of the current university hospital. And at the bottom of this great excavation were some pylons and some mud puddles and a steel strike, which had been going on for many weeks, so there was no progress in the building of the hospital. And the medical school was housed in an old building that was called the Religious Conference Building, and a series of Quonset huts. We used the Wadsworth Veterans Administration Hospital, the old hospital, and we used St. John's Hospital, and we used the Harbor General Hospital, which was also a series of connected Quonset hut type military structures. And that was the part of the beginning of the institution here. When I arrived, the first medical class had come aboard, and it had 4 months of its freshman year of curriculum, class of, I think, about 30, or shortly, maybe a few less.
And then you went about recruiting your faculty. Was that, what was the first thing that you did when you sat down? Well, maybe you want to tell us what the first case was that you operated upon. You probably remember that from...
The first case I operated upon in the newly completed university hospital was a patient with pain, and it was a unilateral chordotomy. One of the very first patients that I saw at St. John's Hospital, where all of our work was done before the university hospital was open, which was in 1955. St. John's Hospital, a private hospital run by the Sisters of Charity of Leavenworth, Kansas, was Bill Longmire's retired, I think, 3rd or 4th grade school teacher. And she came out, and the professor said, "Gene, I want you to see my school teacher." And she had an unusual lumbar 3-4 disc herniation. And I operated upon her, and it was of interest because a number of the orthopedic surgeons that practiced at St. John's came in and looked over my shoulder to see the various things that I was doing and offered the use of various instruments which they had. And I felt as though I was very much on the spot in demonstrating whether I knew my way around in doing this procedure, because clearly I was very youthful, and I'm sure looked it and probably acted it as well.
Well, now, when you came down then, I mean, the challenges facing a young neurosurgeon just out of residency training, setting up a program at a brand new school of medicine must have been incredible. What sort of priorities did you decide on, the things that you had to do first to set up a program?
First thing I recall was the need to have a spectrum of patients that could illustrate basic principles to teach the undergraduate medical students, and to establish a core for the subsequent building of a graduate residency program. And that was not easy to come by. Private practice was meager, in fact, almost non-existent. There was not the most welcoming attitude in the community toward a medical school, in our particular specialty at least, and therefore one relied heavily upon the Veterans Administration Hospital cadre of patients and the patients that came into the Los Angeles County Hospital at Torrance, so that those were the two hospitals that offered our major source of teaching exposure for students. When I first arrived at Wadsworth, there was no residency program, and I was appointed chief of neurosurgery at Wadsworth Hospital, which was the seat, really, of the undergraduate medical school instruction. And we, of course, did not have very many women, and we had no children, so we did take students to the St. John's Hospital and use the Harbor Hospital and St. John's Hospital for exposure to women, which in the case of neurosurgery did not make all that much difference, but we certainly had to have pediatric patients. So that it was a struggle in the beginning to bring together enough patients and develop a caseload to meet the requirements of the American Board of Neurological Surgery and the Residency Review Committee's requirements. That took a great deal of effort and attraction of referrals, and in the process, of course, we recruited other faculty members, moving along more slowly perhaps than some in the medical school were doing. Neurosurgery in general, I think, followed the general policy that we would only invite practitioners of neurosurgery in the community to join the faculty if indeed there was some role that that individual could play in the medical school. And when we had so very little to work with in the beginning, there was not a great deal for those clinical faculty members to do. But that was, I suppose, the biggest problem, was to put together the minimum requirements of clinical teaching material for the students and for an eventual residency.
How did you phase in some kind of exposure to research for the residents?
Very difficult in the very beginning, because my background was not deeply steeped in research. I'd had some exposure in research. It is also true, I should say, that research as carried out by a clinician in those days tended to be applied research. We did have available some laboratory space in the new medical school. We had a monkey house, for example. I talked the dean out of 6 monkeys, and can recall going down to the monkey house without any assistance or lab technician help on a very hot day. The monkey house itself was very hot, and I had caught monkeys in the past, but in this particular circumstance, the geography of the place was not conducive to catching a monkey once he or she was allowed out of the cage. So I chased that monkey around this beastly hot little monkey house with a garbage can lid and my heavy gloves, and finally purloined it, only to lose it, and the door flew open, and out into Westwood Village the monkey went, and up a telephone pole, and that was the last of that monkey. By that time I was so exhausted I didn't have any time left for any more experiments that afternoon. The beginnings were difficult, and yet with the stimulation that we received from the other members of the surgical faculty, all of whom are pretty young. Bill Longmire himself was quite young, and the group that he had brought aboard, with 1 or 2 exceptions, all quite young people. We helped each other, we used each other's resources, we borrowed each other's technicians and equipment, and did the best we could. And the general philosophy of having research in a residency program, which evolved after our residency began, was that there should be a period of time devoted exclusively to surgery. That point of view came into popularity, with me at least, after it became clear that trying to do research in the midst of a heavy clinical responsibility just was not satisfactory. The clinical responsibilities were always dominant. The research always took second place, and therefore we had to develop a system whereby there was sufficient time in the residency that a resident could have exclusively
Sort of a block system,
for
research exposure.
For research exposure.
Now,
right.
You know, and I know that not all of the residents who trained under you went on into academic neurosurgery, but from the point of view of a program chief, how did you feel about research or a research block for somebody who really was destined from the beginning to enter private practice of neurosurgery rather than going on into a research or academic career?
A major concern, and one which would be raised by the residents themselves. Why do I have to spend time spending time in research when I'm not going to go into academic practice? If they knew that, I never encouraged them to admit that ahead of time. I didn't want to hear that, because I had hoped and did hope throughout each resident's training that the individual would be sufficiently stimulated with questions and concerns about pushing back the borders of ignorance to want to enter the academic field, knowing full well that that was an unrealistic point of view. One could not expect everybody to enter an academic field, and in fact, some of our finest residents went directly into private practice, and the private practice community deserves the finest minds as well as the academic community. I believe, however, that research exposure, whether you are going to enter private practice exclusively and know that ahead of time, is a critical ingredient in the development of one's intellectual tools. It is, in fact, itself an intellectual tool. It develops a discipline of thinking, and it, I believe, contributes to intellectual honesty. It certainly should do, in spite of the pitfalls that we see research occasionally falls into today. Nevertheless, I believe that learning how to think critically is a special ingredient that one must have as he or she is analyzing a clinical problem. I think the same kind of intellectual discipline that is honed and developed by research exposure is needed in the clinical setting, as well as in further research endeavors in academic medicine. So even though a resident was not planning to go into academic work, I think a modicum of research training is important. Perhaps not as long. I believe today if a neurosurgical resident hopes to enter a field of research, basic research, about which he has had no prior exposure, he probably will need 2 years in that exposure. Now that probably is more than one should ask of a person who knows that he or she is not going into academic work.
Right. Well, you had, I think, some close affiliations with members of the Brain Research Institute and other departments at UCLA, so that was an opportunity for some of your residents that you exploited, wasn't it?
That is right, and recognizing my own weakness in the area of basic research, it was one of my responsibilities to find mentors in anatomy, physiology, physiological chemistry, biochemistry, and the neurosciences in general. And as the cadre of faculty at UCLA increased and became quite strong in the neurosciences, one had the opportunity then of establishing liaisons between our residency program and the basic science faculty.
Now, speaking of liaisons, when you came, Dr. Rose was already here as head of neurology. And tell us a little bit about how you work things out with him. I know in today's world there are some institutions that have a division of, rather a neurosciences grouping, Department of Neurosciences at some universities. Did you divide up the territory with Dr. Rose, or how was this done?
It was done competitively. And Buck Rose had come from North Carolina. He had been here about 7 or 8 months, I believe, before I came aboard. We always got along very well. We got along cordially, as a matter of fact. I don't think there were any major fallings out. He was very keen about getting a neurological training program launched. We worked together at Wadsworth. We had certainly differences of opinion about the management of cases, about the kinds of cases that should be primarily referred to the neurosurgical services. And when he could not be on hand himself, I can remember times when I'm sure I was highly critical of the way in which neurology residents managed cases, and at the same time tried to communicate my point of view, which was a surgical point of view, to the non-surgically trained.
I take it that in those days there wasn't the idea that some people are promoting today, that the neurologist ought to be the gatekeeper for neurosurgical cases. How do you feel about that?
Strongly. I saw that in action at the National Hospital at Queen Square, and that was in 1948 and 49. All of the admissions, with very, very few exceptions, into that hospital were on the neurology services. And the physicians, in contrast to the surgeons, were the ones who made the decision as to whether a surgeon would see the patient, and if the surgeon did see the patient, whether his recommendations would be followed. It was quite clear that the physicians ran the show, and that approach was contrary to anything that I had been exposed to, and it remains contrary to what I think should be the case today. I believe that the neurosurgical service should have primary admission of cases that are likely to be neurosurgical, and I think the faculty and the physicians, the surgeons on the service, neurosurgical service, wherever it may be, in private hospital or otherwise, have got to be honest enough in the assessment of the patient that when they recognize that this is not a neurosurgical problem, that they will refer it to the non-surgical colleague who can best care for it. Contrary-wise, if the patient on the neurology service is brought in inadvertently on the neurology service rather than on the neurosurgical service and turns out to have a surgical problem, that patient should be referred to the surgeon. I don't believe that a non-surgeon should decide on the indications for surgery, and I think it is important that the non-surgeon and the surgical colleague work closely together, but the final decision should be surgical.
Well, Gene, when you set up the program, you had already been exposed to a number of very fine people that you've told us about, Sir Charles Symons and Earl Walker and Dr. Howard Naffziger, and I think some others in San Francisco that I've heard about. Did you try to pattern the fledgling service along lines of things you had seen, or was the program that evolved and that I encountered when I started with you in 1962 really sort of an amalgamation of the best of things that you had seen?
Well, I like to think the latter. There were certain things I tried very much to avoid. I did not like to see the use of a strictly private hospital setting turn into a preceptorship relationship in which a resident was in effect a gopher for a private practitioner. I did not consider that that was anything other than a prostitution of a residency. Did not want to see that occur, and wanted to see increased emphasis upon the involvement of the faculty throughout the course of the resident's instruction, such that the resident would have, whether he wanted it or not, at his back or at his side, a member of the faculty shooting over his shoulder until such time as the resident finished the program. I know there were some, and are some exalted programs in which once one becomes a chief resident, he or she can do no wrong, is in effect turned loose and decides himself whether to call the faculty member and call for help. I felt that as long as the faculty was worth its salt and the resident was in a white suit, that the faculty had to have something to offer and the resident had something to learn. And so we stayed with the ship until the job was finished.
Well, I think the residents who trained under you all felt the impact of your presence very strongly, usually from somewhere in the early morning hours until very late in the day. And the two things which are most prominent in my recollection were the bedside rounds and your presence in the operating room, which even if you just looked over our shoulder at the time, was always immensely helpful. But let me turn to the bedside rounds for a moment. These were really examples of what you talked about before, the discipline of neurological medicine, the analytical method. Is this something that derived a little bit from your experience at Queen Square, a carryover, the systematic approach of neurological evaluation?
I saw some of the best examples at the National Hospital in London. Sir Charles Simons was a superb teacher, a bit remote from the clerks and the registrars, closer to the registrars than to the clerks. But he was an excellent example. As a matter of fact, almost all the senior physicians were very good teachers. We had as well tutorials by the junior physicians. It was an excellent experience. I had sat through and stood through the experience of having, as a student, my history and physical examination read and annotated by Howard Naffziger. And that was a daunting experience. One stood at the bedside as the professor examined the patient from the point of view of taking a history and from the point of view of eliciting physical signs, neurological signs, and making notes and correcting your workup in the chart. And that could be rather humbling.
Well, I seem to recall, I don't want to interrupt you, but I seem to recall some very similar experiences during my own residency days at UCLA, when we made bedside rounds, and you would be there taking a few notes on the history that had been obtained, always getting out one other little important nugget of information.
I think that that can be overdone. It does take time, and one does need the opportunity for the teacher and the patient and the student to be together, and no barriers put between them. In today's setting, it's much more difficult to accomplish this, I appreciate, where so much of the previous preoperative examination and analysis goes on in an outpatient setting, an ambulatory care setting, as it's popularly called, rather than having the patient come into hospital in advance. That's not so true in the public supported hospitals, the Veterans Administration Hospital and County Hospital, where the patient may indeed be in the hospital ahead of time and be able to stay in hospital a little longer after the time, so that it permits the student and the teacher and the patient to be together, which I think is that critical triad for many reasons.
Tell us about some of the reasons you allude to. I think.
I think the best way of establishing a doctor-patient relationship is through the exercise with its own very important purpose of taking and eliciting a first-class medical history and then carrying out a comprehensive physical examination. And whereas that may be done in your office or in your consulting rooms, you may not have seen the patient until the patient comes into hospital, and the demonstration of this in the hospital with the student, residents, patient, sometimes a critical member of the patient's family if needed for elicitation of historical information and so on, carries out or effects a bonding between the patient and the physician or the team that's there with the doctor. I believe that bond is critical from the point of view of a doctor-patient relationship which is based upon trust and a very careful analysis. And if the patient then says, "Doctor, I have never been examined like this before," and you look at the referring letter and see that it comes from a very well-known person here that you expect would have done the very same thing that you did, makes one realize that physicians can be pressed for time and for other good and sufficient reasons, and sometimes not for any good or sufficient reason, not do as comprehensive and complete an examination as they should.
Well, Gene, I know that none of us are immune from the threat of a medical malpractice suit, but and I'm sure your record must have been close to zero, but do you think that this bonding that you refer to has any role in affecting whether or not a patient might be so disaffected with his surgeon that it might lead to a malpractice claim?
It doesn't provide any absolute security, but it certainly goes, in my opinion, a very long way in protecting against certainly capricious actions, and I believe actions that may have been based on misunderstandings or misinterpretation of an attitude. When the doctor is with the patient repeatedly, having been involved then with the evolution of the case on that foundation of the initial examination and so on, that physician and patient are off to a good relationship. I think it's the urgent, fast exposure in and out, 10 minutes, and you have a problem. The emergency room setting is an example of that. You are part of the problem when you greet the patient in the emergency room setting.
Do you have any suggestions? I mean, today we face the same-day admission system, and as you said, it's often very difficult to accomplish what we accomplished 20, 25 years ago. Do you have any suggestions as to how we might best deal with this and still affect the same kind of relationship, both with the attending neurosurgeon and particularly with the residents who are in training?
No easy answer to that, Rick. I believe that the experts that massage and overhaul the medical care system in many ways overlook a critical need of teaching hospitals. And one does not find in the formulations of many of the pundits an adequate provision for medical school, graduate training programs, requirements in respect of bringing the patient and the teacher and the student together. The ambulatory level of examination and assessment and evaluation and diagnostic formulation is increasingly dominating the scene. Neurosurgery, for the most part, is an in-hospital service. And whereas we do have outpatient clinics, follow-ups in particular, and some screening clinics and so on, we don't do very much ambulatory surgery. Most of the cases that patients that need care have to come into hospital. and some provision for bringing that those various elements for the bonding process needs to be provided, and one, I suppose, can do some of that in the ambulatory care system, but it means then rather awkward scheduling of student time and or resident time. I'm putting the residents in the category of students, bringing the residents from their busy in-hospital schedule to the outpatient setting, bring the surgeon from the busy inpatient setting to the outpatient setting, and the patient as well. Takes longer time for the patient, takes maybe an extra visit or two, ties up the space, so that it's preferable to be able to bring all units together, all elements together in the hospital after all the clinics are closed and time is available to spend in the evaluation of the patient's problem.
Let me talk to you a little bit about your role as a teacher in the operating room, because that was such a key part of the training which you provided. I've already mentioned that you were oftentimes looking over the shoulder of the resident, but I also seem to recall that there was an unwritten rule that anybody short of the senior resident didn't cross the Jura. This was sort of like crossing the Rhine. Do you remember that?
Yes. Do everything down to, but do not open the door till I'm there. Yes.
That's right.
Once the door is open, then problems can develop, and one hopes that there will not be problems, that things will go along in accordance with best laid plans. But the biological systems are not such that they always obey those laws, and they don't always play according to your rules, and so one needs to be very sure that the setting is ideal to open the door to begin with, and then to start that critical handling of neural tissue, retraction if there has to be some, and the management of the basic intradural disease.
When we were residents, and I'm sure the same thing is true today, there's a constant development of new techniques and new instrumentation, and I'm sure that's magnified manyfold today compared to what it was when the program started. But how did you deal, or how does one deal best with the problem of providing residents with exposure to new ideas and yet not becoming a slave to them? How did you feel about that as you developed the program?
That was aided partially by the nature of the individual faculty members that joined the group. And we had aboard Paul Crandall, Bob Rand, yourself, and others subsequent to that, and each brought particular strengths and areas of interest. And that provided some degree of leavening and variety, and it avoided the rigidity that one individual might impose upon a program. It was my belief that whereas a very good idea might develop into a new instrument, and if that instrument could be wielded safely in the interests of accomplishing a specific task, well and good. When the microscope was introduced through the ear, nose, and throat specialty into neurosurgery, we adopted it, I think, pretty much on a personal basis. I think Bob Rand was especially keen to use it initially, and then little by little it became generally applied, and the chief residents enjoyed using the magnification. I was of the thinking, in many respects, that a new gadget did not necessarily change the basic principles of surgery. I think, for example, of laser energy. Laser energy can be just as destructive as a cold knife, or vice versa. the scalpel can be just as dangerous an instrument as applied laser energy. Laser energy was introduced with a great deal of hoopla and great expense, and undoubtedly has applications, and needs to be developed, refined, and applied, tried in the laboratory, introduced in controlled clinical trials, and then presented to the specialty, and let those results then be replicated in another center or two, and then perhaps adopted. I think that if one adopts the newest fad, the minute it appears on the scene, one is not using the kind of prudent judgment that I would believe is important when it comes to taking care of a human being, of a patient, so that I have great regard for the developments that do occur, and the use of magnification, the various kinds of instrumentation that have been available. The micro surgical instrumentation has proliferated remarkably, and I do have to smile because somebody comes out with a new this named after that individual or somebody else's individual, and I think so often the same job can be accomplished with a simpler tool.
Don't have to change hands so many times.
Don't have to
during
change
operation.
hands so many times, and the poor surgical nurse doesn't have to memorize 1,000 different instruments, and the expense is not inconsiderable.
Now, the procedures that you worked with the residents in developing as the standard repertoire, so to speak, in the operating room, were in fact fairly well standardized by you, and as I recall, you were not very eager for the residents to introduce variations because you had some feeling that the residents needed to go out with an armamentarium of some solid neurosurgical procedures. Is that how you saw it?
I think that's fair, and I know that when I wasn't in the operating room and the residents knew that I was not going to be in the operating room, they would adopt approaches that deviated from the standard methodology. My thinking was that the volume of operations that the residents were doing and the variety, you have to put the two together, did not permit that kind of luxury of applying everybody's new approach to a given problem with sufficient experience and depth to make it safe for the patient. And therefore, I wanted to see if the resident was going to expose the pituitary gland intracranially, transcranially, half a dozen times in his residency, that he would need to use essentially the same technique to hone it down, polish it, so that he could do a slick job, and by slick I mean a precise, careful, effective job, not a showmanship job necessarily. By the time he did that sixth and last operation before he left the residency. Now, if he were doing 500, ample opportunity for wide variation in technique. And I think that the same is true today. I believe that, and it will vary on individual services, but certainly on our service, we did not have a high volume service, even though the Wadsworth Hospital, the VA Hospital, the University Hospital, and the Harbor Hospital, and now others as well, each provided some volume of material. The chief resident year had just so many days in it, and I believe to provide a broad spectrum of exposure really did not allow sampling everybody's new technique of approaching a straightforward lumbar disc, for example.
Now, You, I think, were regarded as a general neurosurgeon, or certainly would be in today's world, and you had, as you mentioned, some of the faculty who had special interests in other areas. How do you feel about the development of subspecialization in the larger teaching programs today?
There's a certain amount of it that's going to be inevitable because an individual faculty member will, as you say, pursue a particular interest and become known for expertise in a rather narrow corridor of the specialty. From the point of view of a neurosurgical residency, however, I think if one allows that to be carried to the extreme, whereby there is the aneurysm surgeon or the stereotaxic surgeon, parenthesis pain surgeon, Parkinson's surgeon, epilepsy surgeon, AV malformation surgeon, tumor surgeon, eighth nerve tumor surgeon, pituitary surgeon, trauma surgeon, and so on, it becomes almost a litany that can lead to the ridiculous. One needs, I believe, a breadth of capabilities on the part of the faculty to carry the resident through the majority of the cases that come up onto the service while that faculty member is in the mentor's role, recognizing that if within the ranks there happens to be a faculty member who is especially good at such and such, that attending will then call for consultation from that special source. I think it's very difficult to marry a whole series of narrow specialties together and try to have a cohesive residency designed upon that kind of a foundation. So I think one probably talks out of both sides of his mouth at the same time in many respects. You like to think that you can command in a competent way the vast majority of problems. You also know full well that you may not be quite as good as someone else is in many of those areas that you may attempt to manage because that other individual is doing nothing but that particular kind of a specialty. I believe that a residency needs to have almost all facets of neurosurgery represented in the exposure that the residents have throughout the course of their training, perhaps not necessarily always in the senior and chief year, but it would not be adequate or satisfactory, however, for example, if a residency did not have a head injury exposure. I think that would be a major deficiency, and the Residency Review Committee and the American Board of Neurological Surgery would certainly not look with favor on that kind of training or that kind of a training program. But if there were, let us say, a deficiency in stereotaxic surgery for pain problems on a service, in a residency, seems to me that should that be something that the resident felt was a deficiency that he or she was going to pursue in some way, then that's the place for a prolonged visit to another center, a post-residency fellowship, and the like. And each center has its own strengths, as you well know, yes. Offering fellowships of one kind or another, which we didn't do, however, for a very, very long time. Current chief, I believe, is doing so, but we did not have any specialized programs.
You have any feelings about sub-certification within neurosurgery for certain areas, such as been suggested in some areas?
I have supported the position of the American Board of Neurological Surgery on this issue and have believed that they've been on target in not providing special certification, certificates of excellence or of special training. I think that, and I perhaps am obsolete at this point, but I believe that their position is that It can be agreed to by hospital program. Instructional program can give an individual a certificate saying you have done such and such and so and so. That is, I think, not at the present time recognized by the board, and it may, however, be of economic importance and recognized by the hospital, and therefore aspired to by surgeons who feel they have to have these extra pieces of paper.
Let me go back to our training program. I recall that the Saturday morning conferences that we had when we planned the surgery for the week ahead were a very crucial aspect of the training and the work week. It was also the M&M conference, but my very clear recollection is that you would hold the resident responsible for the surgical plan, though he was not necessarily the one who was really in charge. In other words, one of your colleagues might be the attending, but the resident was always there to answer for the plan. And maybe you'd like to tell us a little bit about how this evolved and what your real thinking was about the resident's responsibility when he would even assist one of the faculty at a procedure, what he had to know about that case.
I suppose one answer to this, Rick, which is not a simple answer, the question is a probing question, would be that anybody who is assisting, let's say being the first assistant at an operation, in theory at least, should be capable of completing the operation if something happens to the attending surgeon. I think that's probably a fallacious argument, but one could use that argument in saying you must be prepared to take the boss's job at any time that is required. Just as the first lieutenant has to be able to step into the captain's shoes if the captain is killed in battle, and so on down the line. The primary purpose for that exercise, however, was strictly teaching, and it was to encourage the resident who was on the pan, as it were, to think on his feet and to have come prepared, of course, having done some background preparation, and to be able to defend and to see the errors of his defense and hopefully correct those errors even in midstream, as it were, and appreciate under the questioning that would be forthcoming some of the fallacies of the resident's position or of the interrogator's position and so on. The Socratic method was and is, I believe, an effective way of encouraging critical thinking in problem solving, such as one encounters at the bedside or in the calmer setting of the Saturday morning conference.
Well, I remember very well one of my resident fellow colleagues in the service, after being on the pan, as Dr. Stearns just put it, finished up and said, "Dr. Stern, I learned a lot from that case." I don't know whether you remember that.
Yes.
That was sort of by way of rationalizing what had happened.
It's a nice balance. I think one can be too rough on a resident. You and I have seen a resident reduced to tears, which I don't think is a positive approach. And I don't recall having seen any tears flow. There may have been more feeling of wanting to grab a cudgel to go after the interrogator, but we usually parted friends.
Well, you've had a remarkably good relationship with your family of former residents, and I think if I look down at the wardrobe today, this is the UCLA neurosurgery tie, which Dr. Stern provided for his former residents a good many years ago, and I think they're still a hot item today.
Right.
Yes. Did you sort of think of your residents as part of an extended family when you were in charge of the program?
I've often thought that I fell short of really making them part of the extended family. I can think of some fine chiefs of service in other institutions in which the relationship between the residents and the chief and his family were much more personal and perhaps much warmer. And I think that to the extent that I failed there, I regret that. I, on the other hand, believe that with very, very few exceptions, you are absolutely right. We had a wonderful relationship, and that continues today. There are many, many personal stories and anecdotes and examples that one could call to mind to illustrate that. But I was particularly fortunate, it seems to me, and I would guess that our residents were my greatest contribution to the field. I truly believe that the talents and capabilities and accomplishments of the residents should exceed the teacher, and to the extent that that's occurred, I applaud it and am delighted.
Well, I know that the garden parties at the beginning of the residency year at 435 Georgina Avenue were a high point in the residency year, and Mrs. Stern and you would be there watching the kids break piñatas and get into all sorts of mischief, but I know they are a lasting memory for everybody who was trained under you. I guess you've kept up with many of the residents today.
Yes, I have, and I'm just, I treasure those contacts, and of course would have liked to see certain members of the residency staff do things other than what they did do, but maybe that was just the sort of parental attitude that extended beyond the residency.
Do you think that as a chief that you are able to give much direction to the residents in terms of private practice or academia, or did you find that most of the people had pretty well made up their own mind what they wanted to do?
The latter, very definitely. And I suppose it's not too different from one's own family.
So
I had
what you can do.
4 children, 3 sons and a daughter, and I thought that possibly one of them might go into medicine. I did not try to coerce, however, nor was I really disappointed, because they're all fine, upstanding citizens. But I would have liked to have seen one a physician, liked to see something of carrying on the professional legacy. But there are many others that can do that, and the residents have done it.
Maybe they saw you working so hard that they decided they wanted to take a different course.
They sometimes fall back on that excuse, but I think they often work very hard themselves right now.
All right. Well, Gene, we've had a chance to break for a little bit, and I wonder whether you could tell us a little bit about what you faced when you came down to Los Angeles, other than the reclaimed desert that is talked about from a neurosurgical point of view.
Right. I was not a very good public relations person when I came down, and I freely admit that that was a deficiency on my part, because I was so involved with getting things going on the Westwood campus and at Wadsworth and so forth, that I really didn't get around to see my colleagues in the specialty in the area. The senior name in the community was Carl W. Rand, wonderful gentleman, who was the chief of the University of Southern California service at the big LA County Hospital, and he was the founding head of that program and remained, I believe, the chief neurosurgeon of the community for years, and was certainly before I came down. And he had spent a year with Harvey Cushing about, I think, 2 years before Howard Naffziger had. It was after Cushing left Hopkins and went to Boston that Carl W. Rand spent time with Cushing. Naffziger had spent time with him when he was still at Hopkins. As a matter of fact, Harvey Cushing asked Howard Naffziger to go to Boston with him, and had he elected to go, he would presumably have been the Gil Horax in those early years. But his mother was ill, and he came back to the West Coast and got things going on the West Coast. Carl Rand had an associate, Henry Cuneo, in a private practice working at the Good Samaritan Hospital, and would attend at the Los Angeles County Hospital. He was not in the same way that the UCLA faculty was, you and I were together, full-time salaried faculty members, different system of compensation. So he had an outside private practice at the Good Samaritan Hospital. Henry Cuneo and Carl Rand and Herbert Crockett were great supporters when we first began to organize a teaching service at the Wadsworth Veterans Administration Hospital. And even after we developed a accredited residency program under the UCLA banner, Carl Rand continued to come out and make rounds, or at least attend a dry clinic, as it were, usually once a week. And you remember those sessions, I'm sure. He was a dear man and continued this for a long period of time, and always treasured his acquaintance. Hunter Sheldon and Bob Pudens had left the Navy and had come to Pasadena, which in those days, Westwood and Pasadena were not connected by freeways in any way. It was always a long haul across town, and they developed a program at the Huntington Hospital. It was following Carl Rand's stepping down that Ted Kersey, who had spent a year at UCLA with us, as a matter of fact, he and I shared an office together for a year, took over the headship of the USC service. And subsequent to that, of course, Marty Weiss took over the program from Ted Kersey. There was also then, at the beginning when I first came down, a service under Phil Vogel at Loma Linda University at the White Memorial Hospital, which was affiliated with Loma Linda University. And those made up the cadre, the Loma Linda program, or the White Memorial Hospital service, the big county, as we called it, the big Los Angeles General Hospital, and the Huntington program. And I'm not quite sure its early status as to its whether it was fully accredited or accredited for a under the full length of time. It might have been accredited for a couple of years. I've sort of forgotten now how that was in the beginning. And then eventually the UCLA program. When I came down, I was not certified by the American board. I'd just come out of a residency, right out of a white suit. And my first any kind of post-residency recognition was when I acquired the fellowship of the American College of Surgeons and then subsequently the board status. And only then was it possible for me to proceed with applying for residency approval. So that there was a delay there because the board at that time, as it still does, requires 2 years of practice before you can sit the examination for certification. So that that was a bit of the. There were some other lights on the horizon, in the field. Cyril Kerrville was one such neuropathologist, cum neurologist, outstanding neuropathologist. His textbook, I thought, still do think, was a fine contribution to the field. Cy Kerrville would come out to the VA on occasion for a post-mortem brain cutting examination. And in those early days, there became gradually a sort of critical mass, I guess you might say, and there was a Southern California Neurosurgical Association that evolved. Trying to recall whether there was such a thing as a Los Angeles Neurosurgical. There was a Los Angeles Neurological and Neurosurgical yes. organization. And the Southern California Neurosurgical was another creature, and its early days, although I was president of it at one time, I would have to admit right now I'm not quite sure of its antecedents. But the transportation across the county was not all that easy, and we tended to be a bit isolated to a degree out where we were, and I think always looked upon as being newcomers and you know, still a little wet behind the ears until things got to the point that UCLA could beat USC at football, although that didn't happen all that often, even in the early years. But we had good working relations to the extent that we had relations at all. I think we were always cordial. I don't think there were any intercity rivalries of any significance, maybe a little competitive school spirit kind of thing, but nothing major. And as I say, with Carl Rand being the person that he was, he added a wonderful glue to the community of neurosurgeons, even though we did not meet together very often.
I was interested, early on you had mentioned that the service really started at the Wadsworth Hospital, St. John's, and the Quonset Huts down at Harbor Hospital, which of course was then our later constellation, Wadsworth and Harbor and Westwood, UCLA. And I do remember the Saturday morning trips to Harbor Hospital and our rejoicing when that freeway opened and it yes. became a manageable task. Early on it was somewhat less than that.
Very difficult. We would take at least 45 minutes to an hour to get down to Torrance from Westwood on a bumpy Sepulveda road. And on a Saturday morning now, I hate to tell you what some of the residents will drive it in. They drive it pretty quickly. One can scoot back and forth much more easily now, fortunately. But it is interesting. We are now today scattered with Olive View out in the Sylmar region and with some neurosurgical activity there, the University Hospital at Westwood, the Veterans Administration Hospital across the Wilshire Boulevard from Westwood, and the Los Angeles County UCLA Medical Center in Torrance, Harbor UCLA County Hospital. You'll have to correct me. There are too many.
No, that's
too many.
I think that's got most of the ingredients.
Right.
When you started in neurosurgery, surely there were a lot of things that were different from a technical point of view than they are today. And I would have thought that aneurysm surgery might be sort of a key example. Can you tell us a little bit what diagnosis and surgery for aneurysms was like when you started out in neurosurgery?
My residency in neurosurgery, I know, had a heavy peppering, and I'll use that word advisedly, of open angiograms, which the neurosurgical residents performed in the main operating rooms of the hospital, and the radiology department would bring along its pack of cassettes and multi-change systems. In fact, in the beginning, they were done manually, and there was just a film at a time. Serial angiography was just in its infancy, and we would expose the carotid artery surgically and bend a number 18 needle into a bayonet shape and attach it without any flexible connector to a syringe filled with thorium dioxide. Thorotrast was its trade name. And fortunately, we did them all on an open basis, because had we not done so, and we had extravasated any of the thorium dioxide in the tissue planes, that could have led to the results of having a thorium dioxide granuloma develop, examples of which I'm sure you have seen and I have seen in Europe and elsewhere, in which the radioactivity of that compound produced severe scarring in the neck area. But we did our own angiography using the Thorotrast. Thorotrast was an excellent contrast material, but it then gave way to Diadrast, and I would hesitate to try to use its chemical name, and subsequently with much more less irritating compounds. Thorotrast was not irritating to the vascular tree, but it was dreadful if it were left behind in the wound. And that was the problem with it, and it was subsequently taken off the market. And you remember, Thorotrast was something that we used as a marker for brain abscesses.
I was going to mention that, yes.
Yes.
You used to have a little secret vial of it in your
up.
office.
That's correct. Probably still there, probably still in the operating room under lock and key. Nobody dares to ask for it today. That's right. Aneurysm surgery was more often than not, at least in my early days, consisted of carotid ligation. And during my residency, I recall very few vertebral artery lesions or posterior fossa lesions, very few vertebral artery angiograms, although there were some performed. They were technically not easy to perform. We tried to do it open. In fact, the ones that I recall were always done open. It was much more of a dissection challenge for the resident at that time to expose the origin of the vertebral artery from the subclavian and inject that vessel without doing injury, so that it was a great boon when angiography became much more readily undertaken activity. I do recall at UCLA, up to the time that our radiologist, Bill Hanafy, went to Sweden, and I'm sure you remember that the neurosurgical residents did the myelograms and did that dreadful test called a pneumoencephalogram and the angiograms. And when Bill Hanafy went to Sweden, he said that, Gene, I'm only going over there to improve my diagnostic capabilities. I have no intention of performing the procedures. So off he went, and a year later he came back and he said, I have to do these procedures. So we had a few eyeball-to-eyeball sessions on this subject, and I must confess that the board's position, the American Board of Neurological Surgery's position, resisted, along with others of us, this move. I can recall that wonderful person, Don Matson, saying, you simply have to keep your hand on those diagnostic studies. In actual fact, once the neuroradiology people, and they deserved the name by that time, did take over, it was a great boon to all of us. And it released the residents' time, it released neurosurgical faculty time, it improved the quality of the studies, and it allowed somebody to focus quite exclusively on the technology, which obviously has blossomed with the catheter invasive technology, which is applied to vascular lesions as well, as you know. Going back to your basic question about aneurysm surgery, carotid ligation, you don't read about very much these days, certain examples, but the vast majority of intracranial aneurysmal treatment is by open direct surgical attack, or by the indirect attack by the catheter methodology with balloons or glues or some combination thereof. The development, for example, of the focused energy source that can be applied to the head is another tool that is available for treatment of aneurysms, but my goodness, by comparison to what it was during my residency, aneurysm surgery now has been revolutionized.
Well, I remember the clips that were available to deal with aneurysms are really antiques in today's light.
Yes.
I'm sure you remember the pool clip and some of the others, and maybe you can think of some that I can't remember, but the ability to take these off and reposition them was virtually nil.
That's right, and if you tried, you frequently injured the vessel to which they were applied. I can remember trying to break the back of one clip that had been applied that needed to come off, and until the little Levacrona clips that had the capability of opening again once applied, until they came along, if you applied it, you were stuck with it.
That was it, yes.
That's
I remember
right.
very clearly one such incident where the carotid broke literally after
Yes.
we
Yes.
had tried to remove the clip.
Magnification, of course, is added tremendously, and the gadgetry, the multiple needle for carrying carrying ligatures, and the dissection instruments, the fine scissors, et cetera, they go on and on.
And neuroanesthesia itself, what was that like in
Another
your starting
revolution,
days?
yes, it was in the dark ages. In fact, there was no such thing as neuroanesthesia. And it took a while. I was raised on the beginning of endotracheal anesthesia. We had many cases operated upon under what you will recall was a barbiturate that was given rectally, and the trade name was Averton. In fact, they say that Walter Dandy would have patients arrive at Johns Hopkins who could not speak English language with a little sign saying, "Please give me Averton." And the myth was that you went quietly to sleep in your bed and you woke up back in your bed and had no recollection of the trek to the operating room or return. Our chief of anesthesia at University of California was a man by the name of Hathaway, and he was introducing endotracheal anesthesia. The professor was not terribly keen about it. He thought that all these drugs that the anesthesiologist gave represented a form of polypharmacy that he hadn't heard defended in a rational fashion. I think little by little he gradually came around to that. When I came down to UCLA, there was a chap at the VA, head of anesthesia there, who was practicing endotracheal anesthesia. He saw no difference between an intracranial problem with high pressure versus an inguinal hernia, and would not give two hoots for any opinion that I might have, young and fresh looking and so forth, and what did I know about what he should do for my patient? So we had some eyeball to eyeball sessions also. Then the university's service opened up with John Dillon, who in his early days was red-headed. He came from Los Angeles County Hospital, and John was a superb anesthesiologist. John, I think, gave grudging acknowledgement of the fact that perhaps there were some special problems in the field of neurosurgery. One of John's somewhat maddening habits would be to walk through the operating suite, generally, all the rooms, and he'd come in through the neurosurgical room, and it didn't matter what was going on or how tense the atmosphere was or otherwise, and he would usually make some asinine comment or ask some silly question as he passed through, having no intention of correcting things depending upon the nature of the answer. Little by little, neuroanesthesia was recognized, and I think we enjoy a major advantage through that means.
Did you still do cases under local anesthesia routinely in the beginning, or?
Not routinely. I carried on an old habit of infiltrating the incision of a craniotomy with local anesthesia, and it was based upon the misconception, I think, that it decreased the depth of general anesthetic that was necessary to avoid movement, and that was a holdover from the days when there was not adequate control of anesthesia, such as came to be with endotracheal anesthesia. The other reason for use of local anesthetic in the scalp was that it would decrease the bleeding from the scalp incision, particularly if epinephrine were added to the local anesthetic agent. And sometimes, of course, just the pressure of the local anesthetic agent itself without the epinephrine could cause some hemostasis. And I can remember using some local anesthetic agent at the time of scalp closure to assist in hemostasis using a little epinephrine with it. Anesthesiologists were not keen about our using epinephrine, and I can understand the reason for that. I hark back, I did not at any time use it, but I asking about old techniques. We worked on a history of neurosurgery at Hopkins, and I can recall looking up in the chapter on neurosurgical techniques, which I was a co-author of, the scalp tourniquet that Cushing used, and others presumably as well. A nice round piece of rubber wrapped around the muslin gauze, which was over the shaved head, and then snugged down with a clamp to decrease the blood supply to the scalp. Those of us that would be concerned about adequate perfusion of the scalp would be rather horrified at that. On the other hand, the scalp was so well supplied that apparently it rarely got people into trouble. I did not use that, but I certainly continued to use, as maybe we still used when you were chief resident, the antiseptic washed and wetted muslin to drape the scalp. That died out by the time.
I don't remember that. Yeah. I do remember the muslin gauze used for the head dressing at the end of the case.
Oh yes, that's right. The handkerchief. Yes,
that's right. But you may be surprised to hear that is also
has died.
Died. In fact, in some instances, the full head dressing has died.
That's right. Yes, I've often thought, you mentioned head dressings, and it used to bother me very much to walk on the ward and see a messy head dressing. It always said to me that the morale here is not what it should be. That if you have a messy dressing, patients and patients' families feel as though they're being slighted a little bit. You jolly well change that head dressing and put on a proper one so that it looks well.
And it usually took the resident, what would you say, a few months before he learned how to put one on in the morning that wasn't off by the time you made rounds in the afternoon.
Always a problem. They would slip off very easily. You're quite right. Globular heads don't hold head dressings easily.
Yes.
Absolutely correct.
Now, pituitary surgery has also changed quite a bit.
Indeed.
From the time that I trained, and I think, were you originally involved with some of the early work when they did, Dr. Hirsch did the transnasal procedures?
I never saw a transnasal procedure until until it evolved at UCLA. And my exposure in San Francisco was to the intracranial or transcranial approach. And you and I worked on a series of cases and studies all based on transcranial work. And clearly today I would presume that not more than 5% or maybe not that many of pituitary lesions are treated transcranially.
I think that's probably true. And I, of course, remember the pneumoencephalograms that we used to do at the Wadsworth Hospital with the patient leaning over a green bread box while we tried to do the lumbar puncture.
Yes.
And then we outlined the air over the pituitary tumor and measured the size of the tumor. All this has been replaced by great new technology.
And I think advantageously so. To the safety of the patient and to the comfort of the patient, pneumoencephalography was, I would have said, barbaric when it was done without a general anesthetic, and if it was done with a general anesthetic, it became an exceedingly cumbersome procedure done in the radiology suite and awkwardly done, not easy to handle a anesthetized patient from the recumbent to the sitting position and then moving the patient into the various postures needed for filling all parts of the cisterns and ventricular system. And we are blessed with the new technology.
Reminds me also of the days of ventriculography when we would place the needle into a burr hole in the operating room and then take the anesthetized patient for studies
cross corridors and at some risk too, because the ventriculographic studies had a morbidity of their own, and it's nice to be able to avoid that as well.
Well, now, going back to neurosurgery in the broader sense in the medical school, it's been said by some people that neurosurgical patients constitute such a small fraction of the total load of a major general hospital, and even among surgical disciplines we are relatively small. What do you feel is the role of neurosurgery in an undergraduate curriculum?
Rick, I think it depends very much on the faculty. I think I was going to say a narrow-minded faculty member, a narrow-gauged faculty member who is focused exclusively on his specialty is not likely to make a powerful argument with either his department chairman or with his dean in getting time for either a clerkship or lecture series or other type of undergraduate medical student exposure to the discipline of neurosurgery. I believe that neurosurgical faculty, however, does have a wonderful opportunity if they will take advantage of it, because neurosurgery is a specialty that is broadly based. It's based on anatomy, physiology, physiological chemistry to a degree, the neurosciences broadly. It embodies clearly the requirement and discipline of taking a comprehensive history and doing a first-class examination, general as well as neurological examination. I think a neurosurgeon should be a good elementary neurologist at the least. And formulation of a diagnosis, problem solving. I agree that I think the operative approach may be limited in its value to an undergraduate student, but at least they can see the pathology. It certainly embodies all of the, quote, intensive care that we talk about today in depth. It involves follow-up, careful follow-up, and recording, annotations. It's a specialty that can be, even in the operating room, surgical principles that are applicable to plastic surgery, to general surgery, to orthopedic surgery, and so forth, providing the instructor is prepared in advance the opportunities are there to make the experience a broad one for the student. And I think that it's a vehicle for very good instruction in problem solving in medicine in general. And because of its excellent basic foundations and its logical clinical progression and the breadth and depth of its scope, in the diagnostic formulation, for example, one has to command and know when to call forth of the broad smorgasbord of tests that are available, the least common denominator that's going to help clarify the diagnosis, and use that and be prepared to interpret that, and then put it together, synthesize it. And I think it's a wonderful discipline to use as a paradigm for instruction in case solving in medicine in general.
I would agree. I know that in the letter which you wrote and which was published in Surgical Neurology in January of this year, 1990, you had made an interesting comment that it's been a long time. I may be misquoting you in detail, but I think you said that it's been a long time since a neurosurgeon has been able to give a generally oriented surgical lecture. And of course, many people know that you capped your career at UCLA as chairman of the Department of Surgery, so that you had a much broader view of surgical problems outside of neurosurgery. But how do you feel? Do you think a neurosurgeon today should be able to hold his own and give a surgical lecture?
Yes, I do. And I think he should have his own roots sufficiently broadly placed in the discipline of surgery. He's going to have to do some work and refresh himself and study up on things. I think that I did even extend that query to any given professor of surgery. There still may be some great great paragons who can today still give a full course of all of surgery, one person. But I think they must be few and far between. The single-authored textbook has almost disappeared. I pull off some of those fine textbooks that are available, and they are maybe 100 authors now. And each one is here we have some facet of colon surgery or hemorrhoid surgery or inguinal hernias or femoral hernias and so on. And I believe that the neurosurgeon, the broadly based neurosurgeon, can make that so-called narrow specialty, and he can't argue based upon the number of cases or the percentage of the nation's ill that depend on his skills. He's got to base it upon his love of the broad field of medicine, surgery, and neurosurgery to broaden the topic and show the application from the narrow specialty to the breadth of medicine. And he's got to have some enthusiasm, he's got to be a bit of a showman, and he needs to love his job. And I think that we sometimes find some of our very fine, technically terrific neurosurgeons that find that the medical student is kind of a fly around here that, well, we'll, get away, don't bother me, I'm busy doing the Lord's work. When in actual fact, if he were doing the Lord's work properly, he'd be teaching that student to carry on the torch after him. You think that a good teacher has to be an actor? I think it helps, yes. I can remember Joel Hildebrand, who I'm sure is a name you remember, taught chemistry 1AB, was a superb chemistry teacher at Berkeley. And before the big game being from an old Cal man, the game between Cal and Stanford, he would put on a show for us. And it was a marvelous demonstration of blue and gold and red in various flasks and foaming and bubbling and so forth. Yes, I think showmanship helps. I think you can end up being a ham, which can then detract from the things that you're trying to get across. I think your display runs a risk, perhaps, of outdoing the principle that you want to communicate. So I think it has to be done with care.
I think you titrated it very well, but I had always suspected until this moment that you were at times deliberately being a bit of a showman, just in the right mixture with teaching how to do a proper reflex examination or how to evoke
yes, I think that's probably true.
Proper response from the patient.
Right, right.
Well, now,
Yeah.
when you were at UCLA, I take it that your sense of where neurosurgery stood in the curriculum of students was looked upon quite favorably by the dean with whom you worked with for many years, Sherm Melenkoff. Can you tell us a little bit about the perception that you have of how, in the broadest sense, a medical school and its dean interact with neurosurgery and the sense that that imparts to the leadership?
Right. Well, I was blessed, and you shared in that treasure, serving with Sherman M. Melenkoff, who was dean at UCLA School of Medicine for 24 years, and he was the second dean, followed the founding dean, Stafford Warren. Sherman Melenkoff is a scholar. He's a superb physician, just a fine doctor in the broadest sense, and even while dean continued to make rounds, although it became increasingly difficult because the deanship these days is almost a gargantuan job. He had, however, a marvelous empathy with the faculty, and I think he had high respect and regard for scholastic attainment and excellence, and wanted to see that cultured in the medical center and in the medical school, and did everything he could to recruit top-flight faculty and encourage top-flight people, and encourage the young people as well. So that we did have a terrific experience being able to maintain within the curriculum, under the pressures of competitors wanting time, and those who took the position that a field such as neurosurgery should be only a postgraduate field, should not be incorporated in the undergraduate curriculum, a position that some of my very close friends have espoused. I do not agree with that, and for some of the reasons that I've mentioned before. Sherm was I think, receptive to the arguments that it should be maintained in the curriculum. It's true that Bill Longmire was also sympathetic to having a clerkship and lecture series in neurosurgery. Bill Longmire had come from Johns Hopkins, where he had served for whatever period of time on the brain team, I think maybe 6 months in the course of his basic training, and had developed a high degree of respect for the specialty. And I think many of the old general surgical chairmen who went through those disciplines of having one of the founding neurosurgical people in his department benefited from that exposure. And when they themselves then established a department, they saw the rectitude and the rationale for having a neurosurgical representation. So we in a way piggybacked on the records that had been made earlier on by the greats of early American neurosurgery. And Bill Longmire certainly encouraged us in our department and helped keep the curriculum in the, keep neurosurgery in the curriculum. Today, it's an even tougher battle because of the explosion of knowledge, the difficulty of jettisoning obsolete material, and without changing the length of the curriculum, still 4 years, more and more to be packed into it. Where does one do the cutting? A difficult chore for a curriculum committee or for the dean, particularly as the pressures mount to switch the training and the education from the hospital bed to the outpatient facility. Makes it even more difficult to maintain what is primarily an inpatient service going in an undergraduate curriculum.
Do you think that the curriculum should be lengthened? Do you think there's a case to be made for making medical school training, or for that matter, the neurosurgical training, longer than it is?
I can't answer that effectively, Rick. I think I can see the arguments on both sides. I think the proponents for neurosurgery would say, yes, lengthen it. The economists would say it's going to cost more money to lengthen the residency, or going to cost the hospital more money to lengthen the residency. Increasing the medical curriculum itself is likewise very expensive of time and resources, money, space, classrooms, faculty. And the question is, do we have the law of diminishing returns come into play? If in the United States we have the finest medicine that can be found, and perhaps some of the worst, are we deficient in our medical educational system? I'm not sure that we are. I think this opens up an arena of discussion which perhaps would be a mistake to try to enter at this point, but I'm not certain that I could defend increasing the length of time of the curriculum, although adding, or let me turn it around, eliminating all summer vacations would not hurt particularly.
One of the subjects that has been introduced into the curriculum, although in many institutions not as a separate course, and in UCLA, Bernard Towers took a lead in setting up some symposia, is the subject of medical ethics, and it's always been a subject very close to the heart of neurosurgeons because we deal so often with life and death matters in neurosurgery. Do you have any feelings about what you as a neurosurgical teacher should impart to residents as they go through the program in sense of medical ethics and how this is best done?
I guess you touch on a subject that gets very close to that term role model. I'm a firm believer that as students we're copycats of the people that we admire, and we like to model ourselves after so-and-so. Why did you enter such and such a program? Well, I liked what I saw in the person of such and such. I think this is what attracted me to Howard Naffziger. Here was a stern kind of a person, but a highly ethical, highly moral individual. That is to say, a person with a high standard of morals and a high standard of ethical behavior. And it was in his life, his family life, in his vacation time, in his personal relationships abroad, as well as in his role as chief of surgery at Cal, and subsequent to that as well. I think that a person cannot have, well, I suppose it is possible to practice a high standard of ethical behavior in one facet of one's life and then not so high in another facet. I think it becomes very, very difficult then at the interface to distinguish, if you don't know what is considered to be ethically correct or not correct, you're going to have trouble if you're not pursuing a code in your private life as well as you do in your professional life. We didn't really teach a standard of ethics, Rick, I don't believe. I think we tried to practice on a high level, a high plane of ethical behavior. And if one found examples that one could use as a lesson, object lesson, I suppose one did point them out and take advantage of them. One that comes to mind, which was not particularly peculiar to UCLA, didn't involve UCLA at all, fortunately, and that was a matter of the fees that were charged when the microscope was introduced into the use of neurosurgery. That whereas operating rooms or hospitals might charge a fee for using the microscope as part of the operating equipment that cost the hospital money, if the surgeon then tacked on a fee because he used the microscope or didn't tack on the fee because he didn't use the microscope, it said to me that he had a Class 1 operation or a Class 2 operation. And if I use the laser, I'm going to add a little more to my fee than if I use the cold knife. Was the laser going to do the best job? Was that his Class A operation? And if so, he had no business not using it. If he could do the operation without the knife, without the laser, and without the fee, just as effectively, safely, and so forth, he should not have used the laser. And this kind of reasoning, I think, might extend to other examples. One needs to work at it, and this is where I believe people such as we have at UCLA can be helpful to us. I think of Les Rothenberg, can alert us to the various ethical dilemmas that are presented, to which there may not be a right and a wrong answer, but one needs to study the issues and discuss them and use as colleagues as a sounding board and try to reach, in the light of his previous background, the best decision of what's in the best interest of that patient.
Well, I think the function of the head of the teaching program, the training program, as a role model is certainly preeminent, and I think that many of the residents who trained under you felt that you were an exemplary role model. And I think this would be a fine time to say goodbye to our audience, and I want to thank you for a fine afternoon. I probably learned a lot of things about the program that I didn't know all these many years.
Yes.
Thank you very much, Gene.
Well, Rick, thank you very much.